Welcome everyone that's already in. We're just going to wait a few more minutes while people go from the waiting room to this room. All right, thank you everyone for joining us and being patient with us as we started a few minutes late. So my name is Angel Gomez. I am a program manager on the harm reduction team at AIDS United, and I'm really happy you're all here to join us. So today we're going to be doing Solo Makes You Go Slow, local partnership addressing syphilis among people who use drugs. And this was put together by the Harm Reduction TA Center with AIDS United, NACHO, NASDAD, the National Coalition of STD Directors, and the Northwest Portland Area Indian Health Board. Next slide. Next slide. So today we're just going to go over some housekeeping, and then we're going to do a little bit of overview, and then we're going to hear some local perspectives from the Cabela Huntington Health Department. Then we'll hear from North Carolina Harm Reduction Coalition. The Arapahoe County Health Department will wrap us up. And then we will share some technical assistance opportunities with you all. Next. Next slide. Okay. So just a few housekeeping things for everyone. So you will all be on mute to help us ensure that we get a good recording to send out with everyone. You can add questions to the chat at any time during the presentation. There is also a Q&A option where you can add questions as well. We do have built-in time for Q&A at the end of the webinar. But if for any reason we can't get to all of your questions, we will follow up with responses to as many unanswered questions as possible. And this webinar is being recorded, and a recording and slides will be made available to everyone who registered following the event. All right, and with that, I'm going to pass it on to Julie.
Hey there, this is Kirsten from NASDAD. I think Julie had some issues with losing power at her house. I know there's some storms rolling through the kind of East Coast, Mid-Atlantic right now. Julie will be back on shortly, but we may need to keep moving to the next speaker.
Kirsten, I think Julie might be trying to get into the room right now. I know it took me a while.
Well, with that, I will just kind of go through the slides that Julie was going to present. Please forgive me as I haven't prepared for them. So just a quick overview. So there are nearly 3,000 local health departments across the country that work to promote and protect the health and well-being of their communities. And these local health departments work across the spectrum of public health, on infectious disease to environmental health, and emergency preparedness to harm reduction. And there are at least 535 syringe service programs across the country that address drug user health holistically and provide harm reduction supplies, but also provide linkage to healthcare and services. And that 535 number is very conservative. That's just the most recent number that have registered with the NASM list. There are many more across the country that are not registered on that list. Next slide. So the role of local health departments. So local health departments can and do address syndemic of STIs and substance use, and they do this in a few ways. So they can provide services and supplies, as well as education. They provide funding or supporting partners to provide these services, supplies, and educations, either in addition to what they do or in place of. They also assess and monitor population health to inform the priorities, like identifying outbreaks and investigating cases of congenital syphilis. And they also address social determinants of health and can do that at a very localized level. And they educate decision makers to inform policies and regulations. Next slide. So when we look at the percentage of local health departments that provide the key services, you can see a lot of them will provide directly, and then there's a smaller portion that they will contract out. And so you can see that with STD screenings and STD treatment, and we're talking about other STDs than HIV because that is categorized separately, that they do about 70% provided directly, and then 7% will contract out. But then as we go back into HIV and AIDS, we see that there's a smaller percentage that are providing it directly and contracting out those services. And then even a smaller amount when we look at substance use services and behavioral and mental health services. Next slide. And then local health departments providing key services, they also do linkage to care. And of those surveyed, 66% did linkage to care and 55% did naloxone distribution, with an even smaller amount of 21% providing SSP services. And then you look at local health departments and MAT, naltrexone, and methadone, and you can see a very small percentage provide those services. Next slide. So at SSPs and the services they provide, as of 2019, 99.3% of those programs offered syringe services. 97 provided naloxone. Again, 97% provided sexual health supplies. But then when we get into non-HIV testing for STIs and treatment, a smaller but still significant percent provide that. So we're looking at 54% of SSPs providing STI testing, and then 39% of those are providing treatment. And it's important to know there was a lot of service disrupted by COVID-19, but many of the SSPs have since adapted or even expanded their programming, and this numbers are pre-COVID-19. Next slide. So local partnerships play a key role with health departments and syringe service programs. They vary from location to location in terms of like the resources, services, and programming, as well as stakeholder and community relationships. And oftentimes they will leverage on each other's strengths to address this endemic. There's a few models of local health department and syringe service program partnerships. One can be the health department providing funding to the SSP. Another can be an integrated service or supply. Sometimes it can just be sharing data and information, and then oftentimes it can be a local health department advocating on behalf of the SSP. And there can be multiple going on at once where you're doing all of them or just pieces of them, and it varies widely from community to community. Next slide. Awesome. So with that, we're going to pass it on to the Cabell Huntington Health Department and Michelle Kirby, who is going to talk to us about their program and their roles. Thank you, Michelle.
Hi, everybody. My name is Michelle Kirby, And as soon as I figure out, okay. I work for the Cabell Huntington Health Department in Huntington, West Virginia, and I run the STI program here, which also encompasses the harm reduction program. So next slide. Just a brief history of our HR program here. We've been here since September of 2015, so about 8 years. And in the beginning, we were open to everyone. We're right on the border of Ohio and Kentucky, so we were open to Ohio residents and Kentucky residents and anyone in West Virginia, really. But in 2018, we had to close our borders, and we're only currently able to serve residents of Cabell County and the city of Huntington. So that cut down a lot of people that we were able to serve. And we are funded by 3 grants, so we're completely grant funded. And of the 500 and some harm reduction programs in the country, we have 9 of them in our state. Next slide. The goals are integration services. When we get a new client, they're screened upon entering as a requirement to enter the program, screened for STIs. And then every 3 months after that, as a requirement to stay in the program and receive clean needle supplies. If they test positive for anything, they are flagged in our system so that the next time they come in, they are treated before they receive their supplies. And then we talk to them, try to get partner information if we can. Most of them don't have, a phone number that we could call like a regular STI client. We also use NSTI HIV and syphilis tests so that we can have rapid information for this population. Next slide. The goals of integrating the STI testing into our harm reduction program is to reduce the infection and spread of disease by providing them the clean supplies and access to testing and treatment. We find a lot of them, if we didn't treat them here, wouldn't go anywhere else for treatment. So that would just make the spread worse. We promote and facilitate referrals to primary health care, mental health, and substance use disorder services. And we also want to reduce the overdose rate by providing naloxone. Next slide. And this is just a slide to show you the difference in a new client and return client as far as the STI programs go. As you see, the new client, they always meet with a nurse before they have access to the exchange. And a return client, they are evaluated as to whether they need to be tested on this date or not, or if they can just go ahead and get their supplies. Next slide. And this is just a type of supplies that we provide to our participants to help reduce the spread of disease. We do provide them with condoms if they want some to help reduce the spread of STIs. Next slide. And then this is the list of tests that we provide here. We do NSTI HIVs and NSTI syphilis tests. We try to do those on all the clients. Some, if they are positive for HIV or syphilis, then we do a confirmatory blood test. We do gonorrhea and chlamydia. We do also have access to rectal and throat gonorrhea and chlamydia tests if they meet the criteria for that. And we also do Hep B and Hep C testing. Next slide. And this is all a list of all of our partners and services that we have. Of course, we have nurses here employed by the health department that see our clients. And then we partner with Marshall University through Marshall Health. And they send a nurse practitioner here 3 days a week to meet with our newly diagnosed HIV clients. And they can see her here, or they can go to her office to see her. We have on-site Ryan White program representatives that can provide access to essential medical and support services. We also have on-site state disease intervention specialists, so that if one of our clients tests positive for HIV and syphilis especially, they can meet with them as they're here, instead of having to try and chase them down or make them come back to try and get partner information. And we also partner with Marshall Health Pharmacy to provide the HIV clients with medication here, so that they don't have to go another place to get their medication. They can come here. A lot of our HIV clients are still part of our harm reduction program. So they can come here, get their clean needles, and also pick up their HIV meds. Some of them get 30 days at a time. Some of them only get 7 days at a time. A lot of them are unhoused. And so they're afraid that someone will steal their medication, so they only get 7 days at a time. Next slide. We also partner with Harmony House to provide the clients with housing assistance. We have on-site community health workers through Marshall Health that can take clients for doctor's appointments if they need to, and help get them in touch with other things that they need. And then we also employ intake care coordinators that enroll participants in our program. We have counselors and peer recovery coaches that they also meet with every 3 months, kind of a check-in to see where they're at and see if they're interested in going into recovery. And then we have several schools in our area that do rotations in our harm reduction program. Next slide. And then some of the lessons that we have learned throughout all this. Early screening and intervention is important. Since a large number of our clients are unsheltered, it's crucial for these clients to be able to manage these diseases early before they progress and further spread into the community, or into the harm reduction community, or into any other community. Building partnerships towards linkage of care. For example, we have people who work for the Ryan White program and people who work for Marshall Health, like the practitioner that we have, they meet and talk about the patients to get them into care. Strengthening healthcare continuity for unsheltered patients. Given the disease these patients are battling, substance use disorder, providing them with continuity of care. We do try to do that here with familiar faces that they trust and they're willing to receive treatment here. And sometimes even go into treatment for the substance use disorder. Some of the challenges that we face is transportation. We don't have currently every service available here. And a lot of these clients don't have cars. A lot of them do have bikes that they ride, but a lot of them have to walk. So sometimes it's hard to walk across town to get to another appointment. Another challenge is multiple site visits for care. It's easy for them to just come here and to try and be a one-stop shop. We found that, they say that they'll come to the appointment, and at the time they make the appointment, they have all the good intentions of making the appointment. But I feel like, it's Maslow's hierarchy of needs. Their need to find shelter and food at the time of the appointment, when the appointment comes, outweighs going to that appointment. So if we could become a one-stop shop, that would be awesome. And also in our community, we have a lot of mental health issues and a lack of counseling for those issues. Next slide. So I feel like we've successfully integrated STI services into our harm reduction program. And doing this helps keep the spread of disease down and strengthens the overall health of our entire community. And that's all I have.
Hey y'all, my name is Reed Getty. I work at North Carolina Harm Reduction Coalition as an outreach worker and a field phlebotomist. So here to talk to you about being on the harm reduction kind of side of things. Yeah, let's get it going. So where I work, NCHRC, is a statewide program. So instead of just like one spot, we like help cover a couple different counties in the state. And we do primarily a ton of direct services at all of these sites, as well as, you know, policy, linkage to care, all the other good stuff we got going on. So those 8 sites are from all the way on the east side of North Carolina to the very end of the west side, and a couple spots in between. So we cover a big amount of area, and we cover a bunch of different people, and we have a bunch of different ways of navigating all of that, because each site, even though we're all North Carolina, operates in its own way and has its own distinct flavor. Next slide. So for phlebotomy in North Carolina, we were lucky enough to be invited by the state to do a field phlebotomy program where they taught us how to become field phlebotomists. At the end of 2019, I was certified through that program. However, not long after that, COVID hit, which made it a lot more complicated. Luckily, we were able to like kind of figure stuff out in the past 2 years through continued coordination with the state and my like ability to be a supervisory staff when people are practicing getting their phlebotomy sticks. We now have 8 people certified in field phlebotomy, and those staff are in varying levels of launching phlebotomy testing through their own sites. So what we test for, we're limited to 4, like our big 4, Hep C, Hep B, HIV, and syphilis. And along with side testing, we offer educational information, preventative supplies, referrals, and linkage to care to people. And that includes like everything from like, if you are moving to a different county, how do you get like stay getting clean supplies, to okay, let's get you set up for testing and treatment right away. So it can cover kind of everything. Next slide. So when we are doing phlebotomy, when we are doing this testing, we have to actually partner with local health departments. Because of the size of the state, because of our own capacities and lack thereof at times, we absolutely have to have these like partnerships set up that are in good faith, that are friendly, because when we are doing testing, when we are getting these samples, we take them to the local health department, help them spin, help them do whatever, and then they get sent off to the state lab to be goes through their laboratory process, everything gets done, and then the results get sent back. So without that key part of being like friendly with your local health department, it is almost impossible to get testing done on this ground here. So if a participant requests to be tested, the staff member will either test them right then and there if they're like prepped and ready to be set up, or set up a time and place to meet them to be tested. Depending on need, we can kind of like figure out what the best option is, which makes it really like nice for a lot of participants, right? Because we can be very flexible, because I'm like totally down going to like the abandoned Kmart parking lot and testing them out of their car, while like our health department was going to have like a lot more barriers to that, and it just like can help them feel more comfortable, etc. So once we draw those blood samples, we go to our local health department to drop off the samples, and of course the very important paperwork, and then deliver. Once it all gets done at the state lab, we deliver those results to participants. If negative, we provide information on how to keep staying safe. If positive, we start the process of linkage to care, as well as sending information about how to keep themselves safe for the time being, and their family, friends, loved ones, community members, how to like make sure that they're staying safe as well. Next slide. So, like I said, we like absolutely have to have this partnership in place to ensure the safety and delivery of our phlebotomy samples. However, it is very real that not every local health department has the same level of staff availability, staff retention, resources, and services. North Carolina has a lot of rural areas, and those health departments, especially during COVID, had a lot of turnover because there's just so much being done that they just couldn't keep up, right? So like when we are forming those relationships with staff, it is very important to like come at it as like positively as possible, and knowing that us dropping off samples is not like their whole world. They're just like waiting for us to drop off blood samples. We are just like a tiny fragment in a very huge process that's going on. So being respectful of their time and space, understanding that they're overburdened, knowing that like for example, where I live in North Carolina is Durham, which is like has like tons of medical stuff going on. Our health department is like by far like the nicest I've ever seen. It has like so many different opportunities and things and going on, compared to one of our rural health departments, which is actually 2 counties smushed into one, Vance Granville, where it is very small, but they do like a ton of great work in the community. It is funny because when I started doing this, I assumed Durham would be where I was going to drop off all of my samples. And turns out that Durham has so many different kind of hierarchies and bureaucratic responsibilities, because they operate just for so many people at like such a high level, that their lab, never called me back after like, 2 or 3 years of trying. I was like, they got stuff going on. So when I reach out to Vance Granville, I like explained my situation, explained that I work with the state, but through a harm reduction agency. And they were super down. They just asked that I come and help them like transfer paperwork, and I just be nice, and it goes super smoothly. It does require me to drive like an extra 30 minutes, but in North Carolina, that's kind of how it goes for a lot of things. So like being able to like really talk to people, it's people who are, running these health departments, just like it's people running nonprofits and trying to like do direct services. So being respectful of people's time, and just like going the extra mile when you can as well. Being like, yeah, I'll like hang out, write everything down, help you process stuff. Next slide. So in the next coming months, we're continuing to train our staff as field phlebotomists. We're launching our Wilmington, Robeson, and Haywood sites for full field testing. And all of those are like very big hotspots. So we're excited to get a lot of numbers coming in that way. And one thing we're very excited to be doing, and it's been stuck in legal for like a year now, is doing a Durham testing and treatment program beginning in fall, which we finally got the health department in Durham on board. And after we went through all of the legal stuff, all of the steps, all of these things, through our mobile SSP unit, we will be able to do testing, which we've already been doing, but also being able to deliver treatment with a doctor on site with us, and be able to do like updated treatment and like different check-ins and stuff like that. And this is like a full collaboration between us, the North Carolina Department of Health and Human Services Communicable Disease Branch, and the Durham Health Department. So it's really like an all hands on deck, getting people the services they need where they are, which is very, very exciting for us. Next slide. So what we have learned for the participants we get to work with, people are often in precarious situations in their day-to-day life. And the idea of handling the implications of testing results can be very scary. So everybody knows it's best practice to test people like as often as they are willing to be tested. A lot of people are not super willing to be tested, and oftentimes like the idea of like a $10 gift card to Target or something like that is enough to tip people kind of into the like let's get tested area. But we choose not to do anything like that, because though if a person is like desperate enough to like do something that they really don't want to do for a $10 gift card, their ability to like be able to handle all of the like resulting situations that arise from the results from those tests can be absolutely overwhelming, right? So when we are doing testing, we like really make sure like people are doing it because they want to, that like they understand like what can happen afterwards. We tell them like, you know, it's not going to be you alone, it's going to be us with you. We're going to make sure you get like to the people you need to see. We can help you all along. But we make sure that it is very informed, because, you know, if a person is chronically unhoused, has a lot of other medical issues going on, having Hep C is maybe not at the top of their like priority list, right? Making sure they have enough to eat that day, making sure they have a safe place to stay that night is probably going to be higher on that list. So both like explaining to people the realities of what all of these diseases might be doing to their body, and like the realities of like what not getting tested and treated can look like, but also accepting the reality of like they are trying to do the best for themselves that day and not forcing them into like really hard corners. So in the sites across the state where we have better resources and linkage to care, people are more confident in getting tested and treated. So in our sites where we have a really strong relationship with the health department, we have like a long-term relationship with participants and communities, people feel much more confident in getting tested, because they know like, okay, like if anything comes back, at least I like know I can text them and get up with them and make sure that like it's going to go the right way. And for us, it's really great because we can be like, yeah, we would love to get you tested and treated. Here's Dr. Rick. We'll like talk to you with him and get everything set up. Because we have, you know, especially in Durham, my boss has been running an SSP there since before it was legal, for like a decade now. So people have a long time with him to be able to trust him and know that he is not, he is always trying to act in their best interest. So we can kind of leverage that trust people have in order to do better warm handoffs to the health department for treatment and for other resources, right? Because people trust us enough to like understand that we're not going to hand them off to some like chop shop that's not there to actually treat them. And what we also like to have happen is having our local health department visit on SSP sites. So that can be mobile, that can be our like physical places where we have like a little office. But it is nice having like the local health department have like a friendly face next to us, so they can like start having conversations with participants, see the needs like right there in the community, and participants are going to feel a little more comfortable getting tested, getting treated, going to the health department. And then we can do things like we've done in Durham, which is a bunch of vaccine outreach, where we got a ton of people vaccinated for COVID and Hep A and Hep B, as well as had people out there to answer just basic health questions for wound care and things like that. So yeah, just building trust, building community, just helping each other along every day is kind of just always one day at a time here. But yeah, and happy to always talk to anyone about all of this. I'm very proud of what we've been able to do and what we continue to build. So thank y'all so much. I think that's my last slide at least.
Thank you so much. Reed, Michelle, thank you. We really appreciate y'all being on here. Reed, there was a question, and I am Julie, by the way. The second, I'm from NACHO, the second that we started launching into this, a transformer in my neighborhood flew, and so I am on my hotspot currently, calling it here. And I just want to give a huge shout out to Angel Gomez for running through some slides that she was not expecting to be presenting on. We will, I think, Reed, there was a question that folks would really like to learn more about the field phlebotomy program. I don't know if there is any information that you can put into the link, or after our next presentation, maybe provide a little bit more information on that. But yeah, really much appreciated to both of you. And then our next speakers are going to be Carrie Knowlton and Clinton Wally from Arapahoe County.
I think
Hello,
Clinton's going to kick us off. Are you there, Clinton?
Yes, yeah, I am here. Sorry. Thank you, everybody, for letting me and Carrie come and speak about our programs. So yeah, my name is Clint Watley. I'm the harm reduction program manager for Arapahoe County Public Health. So we have been offering these services, harm reduction services. We've offered them for 8 years. And I guess I'll kind of bring it back a little bit. We were part of Tri-County Health Department, which was the largest local public health department in Colorado for 75 years. We dissolved at the end of last year, and now we are our three counties that we serve are now have built their own public health programs. So now we are part of one of those. It's been a very stressful couple of years for sure. But yeah, our populations that we serve, as you can see here, are 650,000 people. It's urban, suburban, rural communities. Yeah, and I can talk a little bit more about our program, which we really want to promote and empower our participants of our SSP to really maintain, to improve their health, while also preventing opioid overdose and obviously HIV and hepatitis C transmission within the county. We played a vital role in overdose prevention efforts for the last 6 months of in our new health department. Our staff consists of 4 people, including me, who provide education throughout the county to businesses, to schools, to different parent groups, to government offices, and most importantly, to people who use drugs, who we know are usually first responders to an overdose and are the folks that need our services and our supplies the most. So just a little bit about our program. We do operate under a needs-based model. We do syringe exchange, we do safe disposal. We, like I said, provide Narcan, we do FTS distribution and xylazine test strip distribution. We do the non-clinical HIV and hepatitis C testing, counseling, and referrals to treatment. We connect people to folks that can get them enrolled in Medicaid. We do that with SNAP as well. We also provide referrals to mental health and addiction services if folks need them. And we do wound care education. We also provide safer smoking, safer snorting kits to our folks, as well as boofing kits, which have been a huge hit. And kind of our model of service delivery. We do stuff in our office, which is non-clinical. We also are in the process of getting a mobile unit, which will, we had one at our old health department, and now we're trying to get a new one, which will be great and will help us meet folks where they're at. And then we also just do outreach. So just getting backpacks and heading out and going into different encampments and just being at set places. We also do have a fixed site where we offer our services 3 days a week. Yeah. And then next slide, please. Oh, yeah, sorry, I think it's Carrie now.
Yeah, I can take over. Thanks, Clinton. Yeah, so as Clinton mentioned, we're recently started up this brand new health department, which is not something that happens very often in the 21st century, but we're lucky in that our harm reduction services are part of the health department. So we have both a harm reduction team and a sexual health team. And I'm the nurse manager that sort of oversees both of those teams, and we're trying hard to just integrate those services as much as possible. So we have our STI services look like, we have 2 clinical sites, one in Aurora, which is the biggest city in our district. It's a suburb of Denver, but it's really its own very large city. It's the 3rd largest city in Colorado, and Inglewood, which is another suburban community outside of Denver. So we are primarily a Title X family planning clinic. But we do family planning related services, which include STI testing and treatment, of course, HIV testing and referral. We don't treat HIV, but we refer out, and breast and cervical cancer screening. So our clients that we see for STI testing, we try to see them under our Title X grant. And we provide services. We're nurse-led clinics, so nurse practitioners, RNs, and medical assistants. You can go to the next slide. So with our harm reduction team, we have some of our nurses, a nurse practitioner and a medical assistant, that go out with our harm reduction team once a week. The harm reduction team, anytime they're in one of their fixed site locations or in a place where they're able to, also do rapid HIV and Hep C testing. They are also all phlebotomy certified, so they can do confirmatory testing on site. But it's only on Fridays when we have our sexual health staff that we are able to do chlamydia and gonorrhea testing. What we're really excited about is sometime, hopefully in the next 4 to 6 weeks, we plan to roll out rapid syphilis testing as well with on-site confirmatory testing. So we're planning to use the ChemBio test, which is the joint HIV syphilis test. We will still do we're using the INSTI HIV test, which is the 1-minute test. So we still plan to have that for folks who maybe don't want to wait around for the ChemBio, which is a little bit of a longer test window. But we're hoping to really test as many people for syphilis as possible. As Clinton mentioned, we're hoping to get this mobile unit, which we'll definitely get it. We just don't know when it's coming. We're hoping to get it as soon as possible, probably in September. We are also hoping to sort of expand our STI testing by having our health educators do some of the STI testing. Right now we have our nurse practitioners doing most of it, primarily because we rolled out this whole new electronic health record system that has been just sort of a whole beast to get up and running. And so in order, just the way our system is set up, the way that we receive results, we would need the health educators to be trained in the EHR before they can do the STI testing. But we're hoping to get that going so that they can do that anywhere that's possible, just collect samples and provide some education. And our team is small right now. It's 4 people. So we're also actively expanding and hoping to hire some new health educators and a community outreach specialist. So next slide, please. So our partners are, It Takes a Village, Clinton mentioned, is one of our fixed site locations. It's a nonprofit in Aurora, which is one of our higher needs areas in our county that is really focused on reducing health disparities for people of color in the community. So they do a lot of support groups and outreach. They do their own STI testing, but they give us a space, which is right off of Colfax. If anyone's familiar with Denver, it's a very, very busy street, a large unhoused population, just a really high needs area. So we have a site that we can be at 3 afternoons a week that they give us to provide harm reduction services and STI testing. Colorado Department of Public Health and Environment is our state health department. I saw somebody put in the chat, they were wondering about the cost effectiveness. For us, it is very cost effective to do this ChemBio test because the Colorado CDPHE is so concerned about syphilis that they're giving us these rapid syphilis tests for free. So through our grant, we have to buy the INSTI test, the HIV only test, but they're just giving us this syphilis testing. So that is great for us. And NICHO, of course, is another partner. We received a grant to look at a program evaluation of how we're integrating these services. So, so that is, we're really looking forward to that and looking at ways we can improve. I see another question for whether we have DIS staff. Our DIS staff are employed through CDPHE. So if we did need to call a DIS for, you know, for example, a rapid disease intervention specialist, so someone who could come out and provide linkage to care services and follow up. Next slide, please. So this is something that everybody knows, syphilis. The reason that we're getting these free syphilis testing through CDPHE, our state health department, is because of the rapid increase in syphilis. This is a nationwide problem, I know, but the Southwest has been hit particularly badly. So you can see how rapidly this has been increasing in our state. And we also just received a notification that we have an alert in the county for an increase uptick in HIV positive results, which it was acknowledged that could be also just because of the state, what happened during the pandemic when people were not getting tested as much. You know, there is sort of an uptick nationwide, but we did receive an alert recently. So HIV is also another concern. And next slide, please. So these are just some numbers for what we've done, you know, starting up a new health department January 1st, and already just this year, these are our numbers for who our harm reduction team has reached. So 528 clients, you know, 732 naloxone kits, 1,373 sterile needles. We do a lot of community presentations to teach people about what we do, and naloxone trainings and things like that. So lots of good work going on. Next slide, please. And STI testing. So in the 9 chlamydia and gonorrhea tests is not for our whole health department. It's what we've been able to do out in the community since we're just getting this program going. But our harm reduction team has done 114 HIV tests, 31 Hep C. And in clinic, we've done many, many more chlamydia and gonorrhea. So what we're really hoping is that if we can get our health educators able to do some testing, if we can really get more testing going in this mobile unit, if we can do more rapid syphilis testing, then we can have a lot more, these numbers can go much, much, much higher. We just started our syphilis. At our previous health department, we had been doing syphilis testing for a long time. We just started our treatment program. So we've treated 7 cases so far, but we're hoping with these rapid tests, we can detect a lot more cases out in the community and really increase our testing or our treatment. And next slide, please. So some of our challenges and our future plans, as I said, we really want to increase our volume and just do a lot more STI testing out in the community. As I think every speaker has mentioned, a lot of the folks that our harm reduction team reaches are people who we're just unlikely to see in clinic, who have a lot of distrust of the medical system and have a really, Clinton's team has developed a really amazing rapport with so many of our clients. So being able to to make that connection to people that might otherwise not be seen for testing is really, really important. We're working on getting our mobile unit. We've had some challenges just working. We used to be an independent health department and now we're within a county system. So we found out things like, oh, you can't just buy a mobile unit, you have to do an RFA and get bids and all these things that are very new to us. So we're kind of working through those county processes. Another thing that we have had a challenge with is that when we do have positive results in the community, as I'm sure many people have also experienced, we're working with folks who don't have phones and it's really difficult to follow up. So as others have mentioned, those relationships are really important. And as I said, just expanding the scope of the health educators, having everybody working to the top of their practice and their ability, I think is really important. So thank you. That's all we had.
Hi, everyone. My name is Juan Tirado. I'm an associate with NASTAD. Thank you so much, Carrie. That was really great. And you as well, Clinton. I'm just going to go over a few of the resources that some of the organizations that spoke in today's webinar have that you might be able to reach out to. So the first two I have here are the National Harm Reduction Technical Assistance Center run by NASTAD and our partners, as well as NCSD's technical assistance. If you're looking for more help regarding STIs or stuff like that, NCSD would probably be a better fit. Otherwise, when it comes to general harm reduction things, the NHRTAC of NASTAD could be a good help. And we also have AIDS United and NACHO more tailored towards health departments, and AIDS United more tailored towards, again, generally harm reduction. And in both of these slides, you have the contact information for them. I will be dropping it in the chat in just 1 second, since you can't really copy and paste from the presentation. So here you go. If you want to copy and paste any of those websites or emails, there they are. And we have some time left over for some Q&A. I've been collecting some questions that have been in the chat and in the Q&A section. So if people are ready to answer some questions, I'd be happy to facilitate that. Let me stop sharing this slide here real quick. Make sure everything is good. Okay. One moment, experiencing some slight technical difficulties.
And Juan, I know my
Hmm?
Wi-Fi is a little, I know my Wi-Fi is a little bit inconsistent here, but I can help read off some of the questions that were asked. I think Kirsten was going to be able to help answer as well. I know you were doing a lot.
No worries. I have all the questions up
Okay.
here. So first off, we have a question. We have a couple questions for Reed. The first one we kind of talked about a little bit was that we would love to learn more about the NC Field Phlebotomy Certification Program. So if you have anything more you want to say about that.
Yeah, so through our communicable disease branch, they host a training. I think maybe they do it once a quarter right now, where people in kind of the SSP field, as well as other staff members across like government agencies in North Carolina, they will do like an intensive 3-day training and exam in which you get taught how to do phlebotomy, all the procedures, all the legal stuff. And then after that, you are under the supervision of someone who has already completed it, who is already a certified phlebotomist. you do 20 supervised sticks, and then send that all into the state and you get your certification. I always tell people that like working with our population as a phlebotomist is like nuanced, because on one hand there's like a lot of like, you know, abscesses, scar tissue, a lot of like things that prohibit like a super easy draw. On the other hand, everybody knows like where to go, so you also get a little cheat sheet at the same time. But yeah, that's how the state does it. It's really, really amazing. Our CDB has done a really great job working with the local SSPs, especially because in North Carolina, the health departments don't have the same kind of legal abilities that we at nonprofits have. So they've been done a really excellent job at reaching out and coordinating with us to try and get more expertise on the field, on the ground here. So yeah.
Awesome. Thank you so much. And I think someone here just asked if you know if that certification is available in Oregon.
I am sure there is some version of it in Oregon. I am not sure exactly what route that takes, and if the like state takes that upon themselves. It might just be very, very lucky. But I also, if you are interested in that, I know all the people working in CDB, and they are so great and happy to spread the information and how they do things. So for people with like an interest, feel free to let me know.
Awesome. Thank you so much, Reed. We have another question from your portion of the presentation. What systems does NCHRC have in place to follow up with participants once they send samples to the LHD?
Right. So when we are doing samples, we have the like very official forms that we send in with the samples. We also have for our own record keeping, our own information for the participant getting sampled, which is a consent form that they sign off on, that they fully understand what they're getting tested for, all of that good jazz, as well as a phone number, an address, or some sort of way that I can like connect with them if their test results come back positive. A lot of times, if they don't have that, it's a kind of a thing where like, they're gonna see me in like a week or two when they come by for supplies. So me being able to like have a lockbox on hand with their results in it is like, has been like really useful in the past. But as you know, you kind of are just waiting for that person to pop back up. And then the other thing is working with the state, sending our supplies into the state lab. One thing that happens is if it is a positive for HIV, or if it is a positive for syphilis, it gets immediately flagged, and DIS will take it over immediately. So while I can do support and counseling around the results around that, I am usually not the person doing the like investigation, right? The DIS takes over that part, which, you know, to help to do all of the good work that DIS does. So for that part, it kind of gets shifted off of me onto them, because HIV and syphilis are such a, you know, big deal, and require so much expert like aftercare and like investigative resources to prevent it spreading further. But for Hep C, which is, you know, we have like, I think our rates are between like 40 and 60% of our folks that we test are positive for Hep C. That is something that is like very common. People are like, yeah, like give me the results next time you see me, aren't like super upset about it. But when people are very worried about their HIV, their syphilis status, people are like, okay, like call me as soon as you can. But it just requires me going along with state guidelines about privacy and OSHA, and then making sure that I am doing everything in the right order according to the state. But for the most part, it's pretty much a breeze. And people are usually really understanding for like, if things take longer to get to them because they don't have a phone number, because they don't have an address where I can send something, they understand that sometimes it'll just take another week or two to get to them. DIS, on the other hand, is usually annoyed and then talks to me for like 3 hours trying to like coordinate like a geographic location, but you know.
Thanks again so much. And we have now a couple questions, well, more than a couple, a few questions for Clinton and Carrie. I'm going to start with this one. For the Arapahoe County Health Department, what does your roofie kit consist of, and how do you distribute those?
I'll let Clinton take that one since he's out in the field providing services.
Yeah, great question. Sorry, and it is, I think there was a bit of a miscommunication, not a roofie kit, it is a boofing kit. So, yeah, it's a little bit different. What we include in there is usually 25 gauge syringes. We also include just, hold on, I'm just trying to pull up our form with everything. Sorry. I can actually put something in the chat with just our kind of like our one-page thing that goes into it that kind of talks about everything that goes into the kit, as well as yeah, just some facts and stuff and how to keep people safe.
Awesome, thank you so much. And we have another question for you, Clinton. Why do you think your folks are using boofing kits? I can't get my folks to use them for anything. Too much stigma around butt stuff.
Yeah, I think that definitely you're right. That kind of route of administration is definitely stigmatized for sure. But I feel like yeah, a lot of the folks that we see are just definitely switching routes. Yeah, just switching routes. I mean, people are going from, you know, snorting or injecting to doing that. And I think that it's been great kind of being able to educate folks and kind of talk to them about, you know, just, you know, safety around kind of different harm reduction techniques. But I think that a lot of folks probably, you know, the quick onset of stuff too is something that is a reason why they probably do it as well.
Thank you so much again. And I think this is a question that it might have to be answered separately from the webinar, but someone did ask if it is possible to get pictures and or examples of what some of these kits are for us to be able to duplicate, as well as educational materials that you provide with it.
Yeah, absolutely. We'd be happy to provide all that information.
Yeah, and I'd be happy to send it out with the follow-up email if you want to shoot me or anyone or Kirsten an email with some of those images or resources. I'd be happy to include those in the follow-up email.
Okay.
And I think someone in the chat just put that if you can explain what the kit is.
Yeah, and I'll definitely include that information, but yeah, it's just comes with a needleless syringe, clean mixing cup. We have our sterile stirrers, sterile water. We have lubricant. We wanted to get some different like vitamin E capsules, but we've not done that yet. But yeah, just another way to ingest drugs through the rectum.
Awesome, thank you. And for Carrie, I think, are you able to offer PrEP to the folks that you are testing for syphilis and HIV?
We offer PrEP referrals. Starting up a PrEP clinic is very high on our dream list of things to do in 2024. So not yet, but hopefully soon.
Thank you. And for programs that only are able to offer comprehensive testing once per week, how is the follow-up for clients that are referred on other days of operation, and how do you encourage that follow-up?
If that would be a question for us, I think follow-up has been a huge challenge. So that's something that we are hoping as we do more testing, that's something we're hoping to be able to improve upon.
Thanks again. And I have some more general questions, so anyone can jump in if they feel like they have a good answer for them. Our state has used rapid syphilis tests in the past and have realized they may result in false positives more frequently than other rapid test types. Have these combo tests, are these combo tests sensitive / specific enough?
I can take that one too. We haven't started yet, so we haven't had to deal with any false positives, but one of the reasons we selected the ChemBio is because it is there is a lower rate of false positives. I know the syphilis health check, that has been a big problem for a lot of agencies.
And what are some of the challenges you've seen when implementing STI testing in your SSPs or harm reduction programs? And I think that one is, yeah, kind of for everyone, if anyone has any thoughts on how that's been.
I think with our program at Arapahoe County, I think we haven't had too many issues or kind of speed bumps. I mean, I think, like Carrie mentioned, getting our health educators, trained so that they can offer those services 3 days a week as opposed to the one that we currently do now with the help of with a nurse practitioner. I think that's going to obviously increase numbers. But I think, I mean, I'm not mad at this slow rollout we've had, because it actually is, we've kind of let folks know that we're there providing these services, and, a lot of people don't want to do it, but then a couple weeks later they do, and they know that we're there. They've been able to meet the nurse practitioner that works there and, see how wonderful she is. And it's, I think it's actually been pretty great.
In North Carolina, we faced a couple speed bumps, mostly coming from a lot of our more rural areas of people trying to access the local health department and feeling very uncomfortable. And it has happened in situations before where other SSPs have tried forming relationships before, but we're not always as welcoming and kind. So people already had this kind of notion of what harm reduction people look like and what they do and that kind of thing. And in some of our rural areas in North Carolina, anything to do with drug user health is just people are like, nope, that sounds stupid. So a lot of it has been doing a lot of education to different types of government staff, kind of through local health departments, to try and mitigate some of that. And just always being just really nice and trying to help as much as possible.
Thank you. I have another question here. For an LHD that is considering implementing SUD referrals during STI case investigations, are there any resources or studies that were helpful that assist as an evidence-based practice to support such referrals?
I would answer that question, but I don't know the answer.
Hey, sometimes it's hard to find an answer to every question. And yeah, this seems pretty specific, so it might be hard to kind of off the top of our heads to know one, but it's a good question.
I think I would just ask in that, so with implementing those SUD referrals, I can look up some information regarding that, but I think it would also be what are the questions that they're asking related to substance use during this case investigation. So there is some precedent for involving like SBIRT, which is screening, brief intervention, referral, and treatment. So if those are questions that are being asked, if they're being fielded for that, there's certainly research out there noting that particularly around people 18 to 25, the overlap in both substance use as well as increased diagnosis of STIs. And happy to pass on any of that information. But I can look into that a little bit more for them as well if they'd like. And then for that person, my email is right here. Oh, except for it's ORG, not OEG. Typing's hard.
Yeah, we have a couple more questions here. One in the chat that came in recently is what happens in West Virginia, I'm assuming, if someone does not want STI testing, are they unable to access the SSP?
No, it's an opt-out thing. Like every 3 months, they are told that they have to meet with the nurse to discuss STI testing and vaccinations and things like that. And usually when they meet with the nurse and discuss all those things, they will go ahead and do the testing. But they're not denied access to syringe service program for if they don't, absolutely refuse to do the testing.
Thank you. And are there any regulatory limits on the clinical scope of what health educators can do?
Yeah, I can address that. So we want people working to the top of their practice, but for health educators, since they aren't clinically licensed, we wouldn't have them delivering positive results. If they do a rapid test, they can deliver those results and say, this is a preliminary positive, we need to do this confirmatory testing. But if we had someone coming back with a positive diagnosis, that would be delivered by clinical staff. But of course, all the education leading up to it is fair game.
Awesome. Thank you so much. So those are all the questions that we received throughout the webinar and some we received recently. Is there anyone else who has any other questions? You can feel free to put them in the chat. And at this point, you can, if you feel comfortable, you can unmute yourself and ask it verbally. And if there aren't any questions, if you have any experiences in any of what we've talked about today, we welcome you to share those as well. Well, I turn it over to our presenters again, if they have any last words or final takeaways that you would like to share about what we've talked about today to conclude this webinar.
Thank you all for letting us kind of talk about our different programs and yeah, please, if anybody has any other questions or anything or wants to connect offline, I can, yeah, send Juan my information, and I'm sure everybody else would as well. But yeah, we appreciate you all coming on to listen and learn, and thank you so much.
Thank you so much, everyone, for coming. I think we ended about 10 minutes earlier today, so you can get a little bit more time back in your day. And thanks again to all the presenters. This was really great. And yeah, we will be sending a follow-up email with the recording, as well as some of the resources we talked about that we'd share. So keep a lookout for those. And in that follow-up email, we will also be including a survey. It's a voluntary assessment about safer sex services to inform the work we do in the area. So if it's applicable to you and you would feel like you would want to answer it, it will be there and would greatly appreciate it. So thank you so much for coming today.